Welcome to the Berkeley Demography virtual brown bag. We've had about 6 weeks or so of these virtual brown bags. It's been terrific participation by folks. So as we've done in past weeks, we're going to have 2 speakers, and we'll have a few minutes for questions after our first speaker and a few minutes after the second. And then at the end, we'll have time for more questions, and we'll try to wrap up formally by 1, and then we'll be able to stay on a few minutes afterwards as those who want to continue with questions. So please use the chat function for asking questions during the talks. And I'm going to be moderating today. This is Will Dow, and I'll interrupt the speaker as necessary, or try to parse the questions for the speaker. If everyone else can keep themselves muted so that we have a good Zoom experience, that would be terrific. So today I'm pleased that we have 2 of our own from Berkeley Demography who are presenting. First will be Magali Barbieri, who is Associate Director of Human Mortality Database, and then Josh Goldstein, the Chancellor's Professor of Demography, will be presenting, both related to this topic that you see on the screen of racial and ethnic disparities in COVID-19 mortality in the US, which has received a great deal of attention. And I know my colleagues in the School of Public Health have been using this as an opportunity to call attention to the underlying structural determinants of racial and ethnic disparities in health more generally. And this is wonderful to be able to put some more data and understanding about what might be going on, particularly in this COVID-19 epic. With that, please, Magali, take it away.
Okay, thank you for the introduction, Will. Happy to talk about these topics. So I will first present some theoretical background and some thoughts about the mechanism at play. A disclaimer, none of this is based on my own research. It's a review of what we know so far from various institutions and the scientific literature. And then Josh will present some hard data and modeling. So it will give you the figures to think about this. Oh, I don't have, I can't, oh, here. Okay, so as mentioned by Will, I'm sure you've seen the news over the past 2 weeks since CDC started reporting some of the COVID-19 numbers by race. There've been a great number of articles in the medias and not so much in scientific journals, but it's coming, about the disproportionate burden of COVID-19 on ethnic minorities. As an example, these are data presented by the CDC on the CDC website about New York City, and you can see on the, can you see my cursor?
Yes, we can.
Okay, so you can see here on the upper right-hand side, mortality rates, age-adjusted mortality rates per 100,000 people, and you can see that Hispanics have rates of COVID-19 mortality, which are about twice those of Asian. Asians have the lowest rates, and significantly much higher than for whites, and African Americans have rates even larger, which are about twice the level for whites and 3 times that of the Asian population. So unfortunately, we have very sparse data at the moment, and Josh will address that much more extensively than I do, but this gives some indication together with other reports from different states. Not all states report their numbers to CDC by race. At the moment, they might be 40. It's increased significantly over the past week. But the number of cases, for instance, is not, the number of states which report cases by race is even smaller than that. But they all provide a similar picture showing that the proportion of death of Black and Hispanics is higher than their proportion in the general population, in spite of the fact that their population are typically younger than whites. And so everything else equal, you would expect higher rate of mortality come from COVID-19 in the white population without age standardization than in Black and Hispanics. So there are reasons to expect this differential. We know that, I won't spend too much time on the Hispanic paradox, but by contrast with the Hispanic paradox, where Hispanics have lower mortality rates than white, in this crisis, they have higher rates, and Black have also much higher rates. So Black and Native American, for instance, have higher mortality rates than the rest of the population for all-cause mortality. They also have higher rate of mortality from infectious disease. For instance, 90% of tuberculosis cases in the US are in the African-American population. We also know that minorities suffer disproportionately from catastrophic events. For instance, there have been some very interesting literature about the 1995 Hurricane Katrina crisis that provided evidence of this. And when we think about the mechanism through which this excess mortality of minorities
volume is all the way down, but
exhibited, there are a number of factors that come to mind automatically.
you can't control it.
To think about the morbid process in COVID-19 to organize these different factors. So to die from COVID-19, someone has first to be exposed to the virus, become infected from the virus. Typically, not systematically, but typically people first experience severe forms of the disease that will take them to the hospital and eventually to ICU and the need of ventilators, and then they die from the disease. So this is a typical pathways, though again, some of these steps are skipped for some people. So if we think about exposure to the virus, the place where one lives makes a huge difference, sorry about that, to your probability of being exposed to the virus. We know that African-American populations are more represented in urban areas, and that both African-Americans and Hispanics are more represented in southern states. We know that many of these southern states are Republicans, and they've had later stay-at-home orders than other states. And they also have earlier reopening of the states. And so we can expect that the epidemic will spread more quickly in these areas than in others. We also know that African Americans have very high rates of incarceration, and these are hotbeds for epidemics in general and for COVID-19 in particular. We also know that minorities are more likely to live in smaller and more crowded housing, in multi-generational families where elderly have more barriers to being isolated from the younger population. In addition, where one work and the way people work has a strong impact on exposure to the virus. So African Americans and Hispanics are more likely than other part of the population to work in essential, what's been defined as essential services and industries. So for the Hispanic, it's the agricultural sector and basic manufacturer, and for the Blacks is government services, transportation, healthcare, a lot of the professions which are most affected by the virus right now. Minorities, because of increased or higher rate of poverty, also need to work for financial reasons, why wealthier people who are typically white can stay home and take time off work. Minorities are also employed in professions or occupations where telework is not possible. Because they have to go to work, and because they have low rates of automobile ownership, minorities are also more likely to use public transports, and also because they live in more densely populated areas. So they have access to public transports, which increase again their chance of exposure. There've been some recent work showing that especially African Americans live in communities where they don't have easy access to groceries, or because of limited financial resources, they have to go buy their groceries every day. They can't stockpile because of financial constraints. So all of these factors are reasons why we would expect higher exposure to the virus in these communities. In addition, we know that people who have comorbidities are more likely to exhibit severe outcomes for the disease. And then on the other hand, we also know that African Americans and to a lower extent, well, African Americans and Native Americans, and to a lower extent, Hispanics, have higher rates of underlying health conditions like hypertension, diabetes, obesity, etc., which increase the chance of developing the most severe form of the diseases. They're also more likely to face barriers to care. For instance, there are lower proportions of minority workers with sick leave than in the white population. They also have a lower proportion of health insurance, so there might be more delay in consulting with the medical community. Though, of course, in the absence of treatment, we don't know how much of an impact this mechanism can have. And then in general, we also know that minorities have reduced access to medical care for a number of reasons. We see that right now in the COVID epidemics because testing is more widespread in the white population than in the Black population or other minorities, even though we've seen that mortality seems to be higher in these minorities. These populations are also concentrated in poor states or in poor communities, which have fewer resources in terms of testing, but also in terms of medical care in general, the number of hospital beds, medical professionals per inhabitants, the number of ventilators per inhabitant, and just the number of hospitals in general in poor communities and quality of care. There've also been reports that in some hospitals where there's been a surge in people hospitalized for COVID-19, there've been some triage, and the people who, there've been some eligibility criteria that stress that for intensive care, people with comorbidities are less likely to be admitted in ICUs or on ventilators than others. And we've just seen that comorbidities are more common in the minorities than the white population. And then there is the issue of discrimination, prejudice or biases by medical professionals in general, especially when there is a scarcity of resources which impact diagnosis, treatment decisions, level of care, which are probably very much operational right now in the COVID-19 epidemic as well. And last but not least, the number we see about the excess mortality from COVID-19 in the minorities largely underestimate the issue, even if we had all the numbers we wanted, because the impact of COVID-19 goes much beyond just the number of deaths classified as COVID-19 death. So a quick list of what deaths we're talking about. So the deaths which have been reported by race and ethnicity are those attributable to the virus and classified as such. But there are also a number of deaths which are attributable to the virus but have been misclassified, especially where there is no testing or very limited testing. Then there are deaths from other causes which result from COVID-19 complications. So I was telling you that you're more likely to have severe form of COVID-19 if you have comorbidities, but you also, for the same groups of diseases, you're more likely to have complication from these diseases if you've been infected by the virus. So we've seen, for instance, that there is a large proportion of younger adults, working age adults, who die from stroke after contracting the virus, even though they never exhibited any symptoms from COVID-19. So that's an example. Then there are deaths from other causes which are increasing because of the saturation of medical systems or the lack of treatment, due to the COVID-19 epidemics. And then finally, we can anticipate additional impact due to the social and economic consequences that we can foresee from the epidemic. So I'm not gonna provide you more detail about that, but I just wanted to give you a general theoretical background to try to think better about this issue. So I'm giving the floor to Josh now.
Great, thank you so much, Magali. That's a wonderful overview. We have a couple minutes for questions. Josh, does that make sense to have a few questions now, or would it make more sense to hold them and for you to give more data first?
Oh, let's do questions now.
Okay, great. Let's see. Josh was curious about tuberculosis. Do you know much about tuberculosis as in terms of the prevalence? I assume prevalence by race, ethnicity, and the extent to which we can learn anything based on that.
So tuberculosis, rates of tuberculosis, of the disease and of mortality from tuberculosis have gone down very much over time. But in African Americans, so again, I told you that 90% of people with tuberculosis today in the US are African Americans. The rates of mortality from tuberculosis for African Americans are about 6 or 7 times higher than for white. I don't know what the rates are for Hispanic, but the paper I saw emphasized the situation of African American more specifically. Was that a question, or did you have something else in mind?
I was just reading a question from Josh. Josh, do you have a follow-up on that? Or?
No, that's great.
Okay. So we don't have a lot of questions here, so I'm just going to take the floor. Do you know what we've learned from SARS about the mechanisms underlying race ethnic disparities? I know I've seen a few papers that have tried to unpack them based on data that we know about crowding and about jobs and transport and things. Do you have a sense?
You mean the first SARS virus? You mean the?
Yeah.
Well, I think there were 800 deaths total from that virus, so it's really hard to. Yeah. You know.
And I think there was some interesting information on even incidents. That would be nice to have folks go dig in and start sharing that with a larger community, because there is some research on that. Yeah. Sorry, you're muted, Magali.
Sorry, I saw a question from Nathan, but it disappeared.
Yeah, he said, how much of the racial disparity can be explained by the differential racial composition of employment in essential versus non-essential jobs? Are there any working papers or preprints about this yet?
So I haven't seen anything specific, but that's definitely one of the things that's been discussed.
Yeah, Ron asked about the relative risk of mortality among African Americans relative to others. How the COVID-19 relative risk compares to all-cause mortality relative risk.
So I believe that Josh is going to discuss that.
Okay, great.
So I just my hand raised. Sorry, can I just make?
Oh yeah, please go ahead.
Hi, Corinne.
Magali for presenting. I have the data, and one thing I noticed that was different from the narrative in the news is that for the Hispanic population, it's only disproportionate in New York. No other states are they dying more than their percent in the population. So I think it's just something different from the narrative we're seeing so far, and maybe in line with, you know, the usual Hispanic paradox.
That's interesting. I haven't seen that, but yeah, that's interesting.
Yeah.
This is Don Tryman. I've seen reports in the LA Times that suggest that in California, there is the same pattern as in New York. I can't give you citations, but
yeah.
yeah.
I don't know. I plotted the data. I should double check. I just plotted it for one of these blog posts that had every state, and it was lower than what you'd expect, but I should double check my data sources first.
Good. Well, that would be interesting to share afterwards if you have that.
Mhm.
And there was also a question about, do you know if other countries are exploring disparities in mortality by race, ethnicity, or other characteristics?
I haven't seen anything yet, but I mean, racial and ethnic studies are not as developed in Europe as they are here. They might look at foreign-born, for instance, and I haven't seen anything about that yet, but I'm sure that socioeconomic differences are going to be one topic of investigation in the future.
Yeah, I would think France would be really important. And then there's a question from Claude, whether you have any ideas about why Asians are underrepresented in deaths.
I mean, Asians, is that the question about Asians?
Yeah.
I don't, but that's certainly something else to investigate.
Okay.
Yeah, some of these questions I can try to answer if people want to ask them again after looking at some of the slides I show.
Okay, good. Well, why don't we switch now to you, Josh, and then we'll come back to some of these questions that we didn't get to. There's some good questions about how we would disentangle some of these underlying mechanisms.
Sure.
Josh, you're muted again.
Is that better?
Yes, now we can hear you.
Okay, and Will, you can see the slides?
Yes.
Okay. So thank you, Magali, for agreeing to do this at the last minute. I should say Magali didn't advertise herself, but she's writing something for the French public on this. And so I'm sure all of our feedback will make it to France. So we should give her lots of feedback. This work is early work that I'm doing with Serge Atherwood, who's a new postdoc who just got his PhD from University of Texas, San Antonio, and is joining on in our mortality disparity research at Berkeley. So welcome, Serge, you're here. He's in the audience, so everyone will get to meet him in person when we reunite. Okay, so thanks. I've bothered a couple people about this over the last few days to try to interpret some of our results. So thanks to Ron, Ken, and also to Mike Hout, who helped me out a little bit. They're not responsible for anything I say, but they're probably responsible for stopping me from saying a few silly things. I guess we can share this presentation, but I should say all the calculations are preliminary. Some of them are within the last hour or so. So, you know, please don't cite them without checking to see if we have better numbers. And then the data I'm going to be showing is based on actually yesterday's release of CDC data. The CDC mortality reports, they say themselves, are behind the state, so there's some time lag. It's probably referring on average to a week or two ago. And the calculations I do are based only on counties with at least 10 deaths. So one issue I think is interesting is we suppress a lot of detail. It's suppressed at CDC Wonder, for example, and it's suppressed for COVID-19 statistics. And this is kind of off topic, but I think that demographers should be making a case for whether this data needs to be released more finely, and maybe we should be reconsidering some of these supposed confidentiality concerns. Okay, so what are we looking at? We're trying to measure the disparities. So how big are they? Our data is quite limited, and so we're trying to use techniques to make inferences even with limited data. And then, you know, Magali did a great job laying out all of the potential different causes, and can the patterns that we see tell us something about the cause of the disparity. So I'll spend you know, most of the time on one and two, and I'll try to intersperse comments about three as we go. Okay, so, we have, this is really being called attention to. Just last week in JAMA, we had a very powerful opinion piece, which said a 6-fold increase in the rate of death for African Americans due to a now ubiquitous virus should be deemed unconscionable. This is a moment of ethical reckoning. And this is very much echoed in the public health community, and I would say in the media, and I haven't heard that much from demographers, but I'm sure we'll hear similar words from demographers. What's kind of the same piece kind of cites some of the numbers, how dramatic they are. In Chicago, nearly 70% of the deaths are to Blacks, who are only 30% of the population. In Louisiana, similar numbers. In Michigan, you're getting 40% of deaths with only 14% of the population. So these are the kind of numbers that are inspiring all the newspaper stories that Magali showed. So what's behind this? Magali has already talked about this, and I'm going to present kind of similar thinking, but a tiny bit more formal. So we're going to be looking at deaths per capita, and that's going to be a function of the infection rate here, times the mortality rate of people who are infected. And if we want to think about, well, how could inequality be produced? Well, it can be anywhere along the line. So the per capita infection rate, Magali talked about the ability to isolate. Well, another issue is just where the disease is very prevalent, particularly now we're at the early wave, we're maybe the middle of or beginning of the first wave, or some places towards the end of the first wave. And if you were in a community where the virus hit hard early on, just simply living in that community, regardless of your ability to isolate or not, is going to make everyone in that community more likely for infection. Then we have ability to isolate, and then the infection fatality rate, this second term here, is going to be a product of, say, the background health of people and their access and quality of treatment, both of which Magali talked about. So mortality inequality in this last ratio here can come from here, it can come from here, and there's various pathways within these two terms. And we could probably write out a more detailed decomposition, which would be useful. So we're not going to estimate either of these things. We're just looking at this, and I want people to understand that there are many pathways, but Magali already did a good job of that. Okay. So here's the kind of things that we see. We see the kind of per capita death rate. This is for the United States as a whole, according to the CDC numbers. So these are 17 deaths per 100,000 people in the United States. These are non-Hispanic whites. For non-Hispanic Blacks, about 30% more, higher death rate. For non-Hispanic Asians, about 30% less than whites, and Hispanics also about 30% less than whites. So these kind of crude, these aren't really even rates, they're kind of ratios, because usually for a rate we would divide by person years, and here we're just dividing by the people, and time doesn't really even play a role, but still it's the same idea. Okay, so as demographers, our first issue is age composition. Whites are older than certainly Hispanics, and they're somewhat older than Blacks, and Asians, I'm not so sure, probably depends quite a bit on the place and which Asian community. But comparing these crude rates, the first thing demographers think about is age composition. So we'll want to take that into account. The second thing, which I'm focus on in this talk, is place. So if we want to figure out what the per capita death rate is of, say, African Americans in New York State, most of the deaths have occurred in New York City, so we probably want to divide by we want to use the composition of New York City, not the composition of New York State. And a similar problem plays out, at different scales of geography. Here I'm dividing the deaths which have occurred in very local places by the population which is everywhere. So we probably want to account for the composition, the local demography, or somehow standardize by place. And I'll talk a little bit more about this at the end. I think this is age composition is very unproblematic for demographers. Place composition, at least, is problematic for me and has some interesting interpretations. And then two things I'm not going to deal with. are the consistency of racial classification, of course, matching numerators and denominators. This is especially a problem. Well, this is a problem in all estimates of mortality by race. We don't have a good life table estimate, say from CDC for the Asian life table because of classification issues. It's also true for Blacks, Hispanics, and also whites. And then accuracy of mortality itself. Are we getting the right level of mortality in the statistics? And are we actually getting full coverage or partial coverage of COVID deaths? So I'm not going to deal with these last two issues. We'll be focusing on these first two. Okay, so what we're going to do is we're going to account for both age and place. So far, this hasn't been done. There've been, but there have been attempts to kind of account for one or the other. So CDC came out with a very interesting report. Just I think the first time they did this was last week. This week is the second time. And what they do before they even present these kind of numbers, which they actually don't present, they present this table. So they also present this for individual states. So what is this table? This is the same racial groups that we just had. And this is the distribution of COVID deaths by percent. So 52% of their deaths that they're getting are categorized as white, 21 as Black, and so on. And then they create something called the weighted distribution of the population. So this, what they do here is they take the different counties in the United States and they ask what fraction of deaths, of all the deaths were in that county, and they weight up the population distribution that way. So I'm not sure if that's clear or not, but the idea is that they're trying to do some kind of what demographers would think of as standardization, but they're not standardizing the deaths, they're standardizing the exposure. And when they do this, so I'm not sure what I should know this as a demographer, but the national population for African Americans, I think is more on the order of 13, 14%, maybe even 12%. And when you weight it by the places where people are dying, it increases to 18%. So when you do that, you get actually that there are more deaths to whites than we would expect, only a few more deaths to Blacks than we would expect, a lot fewer deaths to Asians, and a lot fewer deaths to Hispanics. So this is a different story than we were getting here, especially the Black-white differential. Okay, so that's one thing to do, but of course they've adjusted for place, but they haven't adjusted for age. So what does that mean? It means that Detroit and the Bronx and places that have a large African American populations are essentially, we're saying conditional on living there, what's your mortality like? But everybody's mortality there from COVID is high. So it's essentially, it's taking account of place, but it's really taking account of place in a very strong way. Okay, so that's one way to do it. And you can kind of make Black-white differentials disappear by doing that. The other way to do it is to control for age. And so here's an example of what's being reported in California. This is a broader age group, but it's very interesting. If you just look within an age group here, you see that, oh yes, indeed, controlling for age, in some sense, looking within an age group, Latino mortality is overrepresented. This is the population and this is the deaths. White mortality is way underrepresented, sorry. And Blacks are way overrepresented. And here Asians are way underrepresented in mortality, okay? But what's happening here? Well, what's happening in California is that Los Angeles is where most of the deaths are occurring, so we shouldn't be using these denominators. We should be using probably denominators more like the CDC is calculating. And so this is kind of, no one has actually standardized for age and place, so that's what we're gonna do. Okay. So here you can make the disparities seem really large if you control only for age, and here you can make the disparities seem relatively small if you control only for place. Okay, so our approach is going to be to do indirect standardization by age and place. You know, ideally we would like to have detailed information by, I think Jim Carrey just asked this question, can we get things by age, sex, race, in place. I don't know if he asked for place, but I would want place too. And the answer is no, we can't. There's no individual data available that I know of. Instead, what we see are these marginal distributions. So for a state, for example, we would see the deaths by age in one table, the deaths by county without considering age or race in another table, and the deaths by race without considering age and county. So we see those marginal distributions. And as demographers, even BC is now taking on a lot of meanings, right? It's also before Corona, but in this case, it's before computers. We did indirect estimation. We could take these marginal, we could essentially compute rates and apply them even if we only had some marginal distributions. And so here, what that means is I'm not gonna explain too much about indirect estimation. It's probably not obvious how one would do it, but I can explain that if people have questions, but you have to just trust me that you can do it in a way. And the idea is that we're gonna assess racial disparities after having removed the compositional effects of age and place. So how am I doing on time? Okay, so I guess I can explain this a tiny bit. Okay, so we have our census, we have detailed census counts, the number of people by age, county, and race. So that's what we have. And then what Serge and I do is we estimate a standard schedule of mortality by age and county. Now, we don't actually observe mortality by age and county for COVID-19, but we have an age schedule and we can adjust that up or down until it matches the county totals, assuming kind of a proportional hazards type model, kind of somewhat similar to what Ron and I were doing a few weeks ago. And so we have a schedule by age and place, and then we assume that there are no racial disparities and calculate the standardized deaths here by race, controlling for age and place. And then we can do a ratio of the standardized mortality ratio, which is going to take the observed deaths to the standardized deaths. And if it's bigger, that means there's surplus mortality, or the rates are higher than we would expect under equality. And if it's lower, then the rates of that group are lower than we would expect under equality. And then the numbers I'll present to you, I just let the standardized mortality ratio for whites be 1. And so everything is going to just be the relative mortality risk compared to whites. Now, if this were a real brown bag, I could ask, is that clear? But no one can interrupt me, so I can just pretend it's clear and keep going. Okay, so here's the kind of bottom line of our results. Let's only look at the top here for a second and understand how the data is presented. So these are the same numbers we saw before, the crude rates, but just presented as a ratio to the whites. So 1.4 is the ratio of 24 to 17. And 0.7 similarly, and for Asians, 0.76. So blacks are in the crude rate is 40% higher, Hispanics are 30% lower, and Asians are also 30% lower. This is without controlling for age or place. Okay, so if we do age standardization, and this is what New York State has done, for example, then what it does is, because the African American population is younger, once you make them the same age as the whites, or if they were the same age as the whites, they would have 150% higher mortality, not 40% higher mortality from COVID. And Hispanics, instead of having a 30% advantage, they're even more relatively young than the black population, would have a 70% disadvantage. And in fact, the Asian advantage to whites also disappears if we age standardize. Okay, so this is what we have seen, and this is one interpretation of the numbers. Now, let's say we just do place standardization. So place standardization says, conditional on where you are, what happens if you're Black, Hispanic, or Asian? And so it turns out, we already know this, that African Americans are living in places with very, very high COVID-19 prevalence, disproportionately they are. And so the cities where the things are so prevalent, within the city, if you can think of this as kind of having place fixed effects. Within these places, Blacks only have 10% higher mortality, and Hispanics have about the same as they would if we didn't look within the place, and Asian mortality goes down even lower. Okay, so ignore this last line here and just see we have two totally different stories. If we standardize for age, then the disparities look enormous, and if we standardize for place, the disparities look tiny. Okay, so the natural thing to do is to do both at once, and when we do this, we find what we're kind of thinking of as the most believable numbers. So what we see is that African-American mortality is not 2 or 3 times as big, but it's not, also not just 40% as big, it's actually bigger, it's actually 60% bigger than, higher than white mortality from COVID-19. Hispanic mortality, after taking into account both race and place, is 40% higher, and Asian mortality, you can see this kind of, often these are the kind of the averages of these numbers, or rough averages of the numbers, nets out to be a slight advantage. Okay, so we had Ron asking earlier, well, how does this compare to all-cause mortality? Well, all-cause mortality for Blacks is about 30% higher than whites, so that's about half of this difference. And all-cause mortality for Hispanics is about 30% lower, so Hispanics have about, I don't know if it's twice, or I'm not quite sure the units here, but much higher, much more, even larger difference than all-cause mortality. And Asian mortality is somewhat lower, and I don't know the number. We're just trying to look it up. I don't know whether 0.9 is whether Asian mortality is probably on the order of 0.8. So probably there's some disadvantage relative to all-cause mortality, well, which would make sense since there's reasons, especially in the early stages of the epidemic, with out-of-date data, we might get an overrepresentation of Asians. Okay, so this is all at a national level. Now I'm going to look at states. We can do this calculation within each state, controlling for the regional pattern of the disease within the states, looking at multiple counties. And so the states I'm showing are, I guess, is again CDC data, and these are all states that have more than one county reporting more than 10 deaths. And I've drawn a line at 1 for the to show relative to whites, and I've drawn a line at 1.3 to show what we would expect if COVID-19 mortality for African Americans followed the general pattern of being about 30% higher than all-cause mortality for whites. And I guess contrary to what Magali said, I mean, Magali's definitely right that most states certainly show a disadvantage for Blacks, but some states actually show basically no differences, or maybe even a slight advantage. We can ignore the zeros here; those are just data problems. And we see that Ohio, at least in the data that's reporting, is Blacks are actually doing a little bit better. Massachusetts, Indiana, Washington, New Jersey are all doing about the same, or maybe a little better than what we would expect from all-cause mortality. And then the states that are doing really badly are a mixture of southern states, Louisiana, Alabama, South Carolina, urban northern states, Wisconsin, this is very much driven by Milwaukee, Illinois, very much being driven by Chicago. And so there's quite a bit of variation. It's very interesting to look at this. So these numbers kind of just hot off the press. I wouldn't run too far with any of them, but you can get a sense of what we can do with our method after we've double checked it a little bit more. And then if we look at Hispanics, here's the same plot. There are fewer states that have enough cases. And we see that some states, so here I've drawn the Hispanic advantage here. So Hispanics are also doing worse, kind of across the board, except maybe in Florida. Louisiana I would discount because I don't think that's a very large number of cases. Florida is interesting. And then you see that, and Nevada I probably also discount because I think it's a small number of cases, but you do see a fair number of states that are having Hispanics do worse by roughly double whites, and some cases where it's not as much. And here's California, about 50% higher. Okay, so the data was showing us different things. At one point, I thought the disparities were disappearing. Now I'm fairly convinced that the findings we have are fairly robust to coding errors, et cetera, et cetera. And we're finding, the big story is that these racial and ethnic disparities are large. They are larger than what we'd expect from all-cause mortality. And I think Magali told a detailed story about why we might expect things to be worse for COVID-19. And it's not just a question of the usual access to care and the usual health conditions. Nationwide, Black-white disparity is about twice as high as all-cause mortality. That's the 1.6 versus the 1.3. And nationwide, the Hispanic white all-cause mortality advantage is reversed in the COVID epidemic. So Hispanics are advantaged for all-cause mortality and have a big disadvantage regarding COVID-19. So I think my interpretation of this, and there are many things going on, but my interpretation of this is that it's mostly a question of differential infection rates. Part of this is that the disease is not uniformly spread over space, and even though we're controlling for counties, we're not controlling for all the sub levels of geography. And so there's communities that have more infection, communities that have less infection. That will probably change a little bit over time as the first wave kind of spreads out. But the big issue here is probably ability to isolate and the requirement to have to keep going to work and to keep going to work in conditions where you can get infected. And I think that the fact that we see the differences are so large for Hispanics, 1.4 as against, I'm sorry, where we would expect it to be about 0.7 if it was all-cause mortality. It's just an enormous difference, which I think is mostly going to be due to the exposure of Hispanics. In that sense, the additional Black disadvantage is smaller because we would expect already from health disparities to be about at 1.3.
Good. So Josh, we have about 4 minutes left.
Okay, I'm done in 30 seconds.
Okay.
And then the last thing we see is lots of variations by state. So New Jersey versus Mississippi versus Wisconsin. So I think that the standardizing for place makes a lot of sense now at the onset of the epidemic, where infection rates and mortality rates are so different by place. But in the long term, we probably don't want to do this, or we want to do something better, because part of what's driving the differentials by place is, of course, the same structures of inequality that are driving the racial disparities. So if we continue to control for place, especially if we do it on a very fine level, we'll essentially be hiding a big part of the disparities. But for now, I think this is a good approach. Thank you.
Great, thank you, Josh. We'll give you a little round of applause now. And we have a number of good questions here that are coming up. And there was some discussion, Corinne and others, about your last point about whether it's sort of controlling away some of these long-term structural factors if we control for place. So I think that there is a lot of debate about that even early on in the epidemic, the extent to which that's the correct thing to do. I do think that it's very interesting to look at the differences by place. There were a couple of questions about.
Can I say one word about that?
Yeah.
So when I was discussing this with Mike, he said, in line with a lot of his research, is that you can start putting in a lot of explanatory variables for place. Whether it's air pollution or the occupational structure or whatever it might be, to try to get at this. So I think that's certainly a way forward.
Yeah, so there's some questions about data. One is there selectivity in what types of counties are reporting right now? And a related question was, we know that the coding of COVID-19 has been a problem in the cause of death. So if you were to use excess all-cause mortality, is that something that you could do and repeat this?
So the first question, I don't know the answer to. I know the number of counties reporting increased a lot between this week and last week because they used the threshold of 10 deaths. And so there were a lot more, unfortunately, a lot more counties where there were 10 deaths. I think it's about half of the national population is what we have covered right now in these counties. But it's, I think it's 80 or 90% of the deaths, or maybe it's even more than 90% of the deaths. So that's one answer. The second question, could you just repeat that about the all-cause mortality?
Well, we know that the coding of COVID-19 deaths is problematic, and so demographers have been looking at the all-cause mortality and looking at excess mortality over and above what we would have projected from prior years. So could you actually calculate the excess mortality for each of your cells and show this by race ethnicity?
Okay. No, I don't. At least I haven't seen any kind of detailed excess mortality by county or age or anything like that. There are, like the New York Times is doing a great job trying to track this. I believe it's doing countries. I think it's doing states. So but that's something one could do in the future. Now, why would I could argue on the one hand, on the other. On the one hand, even if we're underreporting, as long as we're getting the racial distributions right, everything would hold. But on the other hand, we may not be getting the racial distributions right. We may not have the nursing home deaths, which probably have a different racial composition than the hospital deaths. We may not be getting the at-home deaths, which probably have a different racial composition than the hospital deaths. So those are both good points. And I think we're all searching for the answers on those things, and that will emerge as we get more and more data.
Yeah. Hillary was also asking about the prison population, if you know anything about how the demographics of the prison population would affect any of this.
Super interesting. CDC is not giving me any indication of where people are dying, but local dashboards are. I believe, it's not uniform across states, but you can start kind of hunting around. Where did I see this? I think it was some of the upper Midwest states, Michigan, Wisconsin were reporting some of those numbers. And sometimes it's even, the dashboards are even more detailed by county. So Milwaukee County is, has really been hit hard, and that's an interesting place to look. So one could probably, one could learn a lot by kind of harvesting those dashboards. But it's an enormous amount of work, and it changes every day. And so in some ways, even though CDC is behind, I think we should be grateful that they're doing this aggregation work.
Yeah. Tim was asking if you could actually control the zip code level if you wanted to try to do an even more intense control.
So I don't know enough about the statistical system, but I believe that the testing and positive cases is part of a national reporting system that requires zip code level information. And so that's just standard across all the states. You see a lot of zip code information on cases and positive tests. So you could you could repeat the analysis for cases, and you could, you couldn't use the census data for zip code, but there are zip code files that one could use. So great project.
Okay. There were a couple of questions asking where New York was in a few of your graphs. It didn't look like
yes,
your later graphs.
New York City and New York State are separated, and we haven't quite done that in the denominators. So sorry, tune in. We'll get that. If the brown bag would have been at 4 o'clock, maybe we would have gotten that done.
Yeah. And for some of
the answer, I think, is that it's somewhat like New Jersey. They're not. Once you control for space, even within New York City, you really reduce the disparities if you want to control for space.
Yeah, and for some of your states, are there just so few deaths that looking at some of these negative disparities, is that just statistical noise?
I think it is for Louisiana. I don't think it is for Florida. Let's see. Ohio, I don't know what's going on. It may be a reporting thing about which counties are reporting, and we may not see, some of the very African-American counties, and that should be taken into effect, but it's still just going to be compositional. I think Massachusetts is probably fairly good, although it may be still early in their epidemic. Washington obviously has a small African-American population. New Jersey's probably a pretty good estimate. Again, these will change next week. We'll get the answer to that, of how much these changed. We didn't see huge changes when we calculated last week and this week. So it's not that quickly moving. Another thing that's interesting is how the racial composition is changing over time. And one might think that the early distribution of deaths is going to be about exposure, kind of which places got it, and that people weren't social distancing, just kind of random. And that the later distribution of deaths is going to reflect a lot of who was unable to shelter in place or isolate. And so by differencing those two things, we may be able to learn something about the role of isolation on inequality. I should say our preliminary attempt to do that didn't show a big change, but the data wasn't very good either.
Yeah, well, it's 1:04 now, and there are a bunch of other good questions and suggestions. I think there's a whole army this could occupy a whole army of researchers to look at these questions. As Sarah Reynolds was just saying, wouldn't it be fascinating to look at this for the flu and what the differential is for the normal seasonal flu over the last 10 years? So I think there are lots of good ideas here. Why don't we pause and give a round of applause for Josh and Magali again. Thank you so much. We will save the chats and if I don't know if Magali or Josh, you'd be willing to reply to anyone on those if you have good good replies for those. This is being recorded, so we will put that up as well. So why don't we end the formal session now, and then we can continue on informally for people who want to open up their mics and jump in and chat.
Thank you, Will, for moderating. Next week, we'll have Ted Miguel and others featured among other speakers. So tune in again next week. And thank you, everybody, for the response that you want this to keep going. I'll repeat my call for people who want to present. Contact me, please. Anybody who wants to organize a panel and give me a week off, I would be even more grateful if they wanted to do that. So thank you, everybody, for your feedback. And I should say, we're taking the transcripts, and a new tradition was started by Adrian Raftery. We sent him the transcript, and he sent us answers to the questions. And actually, that was done last week, too, by David Rare and Jessica Metcalf. And so we'll post those. I've been posting those on the DMOG blog, but maybe we'll do that here, too, if we have the energy.
If you could post the link to the DMOG blog, which I bet everyone here has.
It's just DMOG. I'm looking for chat room. I can't quite get it up. How do I get chat room up?
On the bottom, it should be chat. It's one of the.
So I think the problem is I'm sharing or something. Stop share. Now it's better. Yeah, there we go. They don't allow you to chat while you're presenting.
All right, so feel free to open up your mics and chat, folks. So thank you all so much for participating.